What were you seeing 5 or 6 years ago that is the same and different than today?
It became clear that the cost of healthcare was really rising as a stumbling block, and something was going to happen. And there's been lots and lots of hand-wringing about it, but it became apparent to me that one of the things going on in the backdrop that people, I think, underappreciate is that for at least 15 or 20 years, we've been on this progression of major employers switching to self-insurance. And that for many of the healthcare payers, the insurance companies, more than half of their business was, and still is, managing self-insurance plans, not really bearing the insurance risk, or at least not fully. And this signaled to me that, you know, when you think about the cost of healthcare, and you just think in cold analytical terms about who has an incentive to reduce the cost of healthcare, it's not the providers. I would argue it's not the payers either. I mean, they're selling $1 worth of healthcare for $1.05 and living on the margin. They have no financial incentive to go to 60 cents. The only people with a real incentive to lower the cost are the people who are writing the checks. And there's really only two of those. One is employers, and the other is government at all levels. A little bit consumers, but not much. And the observation that really provoked me was the notion that the movement to self-insurance and the increasingly aggressive stance by Medicare was an indication that the people who write the checks had economic power, they were recognizing it, and they're starting to throw it around. And if you look at who's really causing the move to value, I would argue it's those folks.
There are some trends that I think are stickier than others, and I'm wondering if in your exploration with the sort of innovator to employer to consumer model, because we hear about consumer experience, et cetera, all the time, are you seeing some trends that are stickier than others that employers are sort of honing in on, and that employers are picking up, or that consumers are picking up on, that are actually making a difference?
I will tell you that in my casual observation, the people who mention consumers the most are the innovators who have come out of the software industry. And they think that the world revolves around consumers and consumer decisions. I regard that as a premise, not necessarily a fact of healthcare. I'd like to see it debated. What do we know about the role of the consumer in today's decisions and in tomorrow's decisions? I don't know how that's going to play out. What is the CMO job in this new environment that you're in?
So in this new environment, and the reason why we created a CMO job at the university was primarily based on three things. The overall idea was to give a powerful voice to a physician in the administration so that decisions regarding care of the patients or services or whatnot were to some extent in the hands of a physician administrator, somebody who could be a physician administrator. But the three bases of the job that I have, every university, every health system crafts it differently. For me, there's one part is the integration of and the coordination of all clinical services done through the hospitals. We own or operate Harborview, UW Medical Center, Northwest Hospital, Valley Medical Center, a large neighborhood clinic component. So coordinating on that so that everything has the same flavor and that we practice in a safe environment, but we also do things in a similar way. The second one was the integration into that system of education and research, which are two other activities that we are well known for. And how do you integrate that interface to make sure that the patient safety and quality continues to be good while education and research are there? And the third one is care transformation, the general field of care transformation.
We all talk about, okay, healthcare is changing. We don't know quite how, but it's changing and it's under a lot of pressure. And then in the clinical end, we hear about care transformation, which to the outsider says, well, you're going to change the way you take care of patients. What is care transformation really, and what themes do you see emerging there?
You know, first, for those of you who are perhaps not hearing the term, or hearing the term all the time, but wonder what it means. It means different things to different people, first of all. So we have to say care transformation for us, and perhaps we can get into a little bit deeper later, why do we need care transformation, but to us was to transform the way that we currently provide services to patients into a better way. How do we do that in our environment? There are numerous possibilities that you can tackle. We decided to take on 6 major areas, 6, laser focused on 6 areas. And then we created a couple of initiatives around those areas. And those areas were, first, standardization of processes, procedures, functions, etc. So we could imprint our brand, if you wish, on something. We could decrease inventory. In the past, everybody did it his way or her way. That's how I learned. I use this, I do that, I move right, I move left, because that's what my teachers taught me. But everybody does it differently. So if you standardize, you become more efficient, you become safer. It's easier to teach to somebody, so I don't teach somebody how to operate and they say, well, at Harborview, they do it opposite, right? And I'm trying to learn 2 different things. Standardization, big first focus area. The second focus area was population management. And maybe we got to return to that, because now we move from the sporadic, one person at a time type of care that we gave to the management of the population. And if you want to think population management, you think the opposite of providing care to a patient that is in front of you. It's providing care to those who are not. Providing care to those who were supposed to come back and didn't come back, have diabetes and didn't get it checked, are depressed and you don't know what they are doing with their medication, how much they are taking because they didn't return to the clinic. So it's turning the thing upside down, knowing exactly how many people you are responsible for in the primary care environment, and then deciding, I need everybody on my panel, a new term, right? I'm responsible for this, for you all here. I'm the primary care physician, so I'm responsible for you all. This is my panel, and I need to know how many of my panel have had preventive medicine, how many of my panel are women, are men, what ages do they have, what weights do they have, and all the things that have to do with health. So it's population health, a big, big thing. The third one is the establishment of a medical home. In order to provide population health, we need to divide the 500,000, 600,000 people that come to our place into chunks that are measurable and provide for those chunks of people a group like this. I'm your primary medical home. I have a nurse, I have a technician, I have somebody else. You can call any one of us. We all know that you are Laura Smith. And Laura Smith, I hope that we don't have a Laura Smith here, but you are Laura Smith, and you can call and we say, oh yeah, Laura, you are due for your mammogram, for example. I just see that. Why do I see that? It's the fourth topic, which is better use of clinical information systems, better use of computer technology, so that if you call me and your name is Laura Smith and the phone rings, my computer says Laura Smith is on the phone. Pretty easy and standard for iPhones and stuff like that, but not in healthcare. And immediately below that, it opens the chart and it says Laura Smith is due for tetanus shot or colonoscopy or whatever you're due for in terms of that. Or Laura Smith has not been in the clinic for 7 months, exclamation mark, she's on antidepressants. You can extrapolate from that. Better use of technology. So that's the fourth area that we are devoted to. The fifth area is what we call the healthy you, and that is, as we can discuss if you want to go that way, what risk management is. If you, let's say, you are all employees of a company, and I am your primary care provider, and you are part of my panel, my pack, all of a sudden my interest in this new world is to keep you all from seeing me. It's to keep you all safe. So have my technician call Laura Smith and say, you get the mammogram, and have somebody else call somebody for a colonoscopy. They discover a little adenoma, they take it out so you don't get cancer. Being taking care of everybody in a healthy way. Have somebody that is obese saying, hey, how about going to the nutrition clinic, and so on. So it's keeping people healthy. Have wearables that you can come in and we can hook them up and say, okay, I see that you are not exercising 4 days a week as you told me you were. How many steps did you take yesterday? How many? And you know, these things happen. You can come to my watch and see how many steps I took today. Number 6, and the last one, is in contrast with standardization, which was the first one I gave you. The number 6 is what we call smart innovation. Every day you turn on the TV in the morning and you say, I have psoriasis, but if I take Zomira or Humira or this, I don't have psoriasis anymore. And the next day you turn in and says, take Xarelto, don't take warfarin anymore. Well, Xarelto is $2,000 a pill, warfarin is 20 cents a pill. And you know, those kinds of things. So innovation is coming up all the time. And I'm not having anything to say against or for Xarelto. All I'm saying is smart innovation is a new process that has to do with implementation science, where scientists actually look at everything that is costly and makes a determination based on good evidence whether we're going to take that or we're going to leave that.
That's an ambitious agenda. And it's predicated on several premises, it seems to me. It's interesting to me that nowhere on your list was maximizing revenue or anything else. It was all about care transformation. I really appreciated that focus. But how does that happen in a big, you know, I'm reminded of the old jokes about redesigning the airplane while it's in flight, right? I mean, that's what you guys are doing, isn't it?
Yeah.
And UW is a monster. It's what we call an integrated system. Is that the phrase we use? You could do everything from primary care clinics to quaternary care.
You can consider it an integrated system because we do the whole gamut of care. But in today's world, integrated systems are systems that are actually functional integration systems, so that where we are driving to, what we want to do with better use of technology, is to be interconnected enough and to be standardized enough that from the outside world, if you come as a consumer of healthcare, either healthy consumer of healthcare or sick consumer of healthcare, you come into a system that can intercommunicate rapidly between one another. So integrated systems are systems that can function in such a way that in a very smooth fashion, from the point of view of the consumer, we can do the transference of care.
This doesn't just happen by spontaneous combustion. What's driving it? What are the forces?
The overall force, obviously, you all know what it is. It's the paradox that we see in this country that can be explained. It's the paradox of having an exponential growth on the cost of providing health care when compared with any other country, the developed country of the world, and not having an exponential growth on the outcomes of that cost, right? Let's say the outcome is how long do you live? And so we compare ourselves with 6, 7, 8, 9, 10, 15, 25 other countries in the world, and we still live less time than those other countries live, right? And yet they are paying 1/4 of what we're paying. How are we so expensive and yet not obtaining those good results? So that brings us to more the topic of that is what's driving, that's what started the drive by society, represented by Congress and the government, to say, we can't afford this. But the only way to put a stop would be if we were forced as a society to provide services that added value and to start measuring value in healthcare. And that is a very difficult, it's a difficult topic, it's a difficult way to walk through, because unless you understand value, you don't understand why we're moving in that direction. You have to make first the decision of what are you going to call outcomes. And I would submit to you that the best way to define outcome would be to think of it as a large number of pots. So you can say outcomes from the patient's perspective, right? You have pain on your back, You come to see a surgeon, an operation is done, and you go out and you have no further pain, or so you say. That's your outcome. Outcome from the point of view of the company where you're working is not that. It's not that. Outcome is, I paid for a portion of your care. You had back pain that made you be absent. You were not coming to work. So I want you to be in the company every day now that you say you don't have pain. If you are the patient, you can say, all that is important to me is not to have the pain. If you're the company, you're going to say, all that is important to me is that the person is here. And is as productive as it was before. Otherwise, instead of being absent, you're being present in the presentism form, right? You're there, but you can't work. That's why it's difficult to put a number on it. But depending on the angle that you look at it, that's what outcomes is. Risk is a different concept now that we in healthcare, for a long, long time, we acted like an airline. You want to go from here to San Francisco, this is the ticket, this is how much you pay. I give you service, you give me pay. The problem we have right now is that we're in the midst of still living in the past while moving into the future, right? Right now, if you come into the emergency room and you are on the fee-for-service world, we get paid. If you get readmitted, we get paid. Any service that we provide is like a cup of coffee. You want another one? Another one. You want 3 times? 3 times, but I get paid 3 times, right? And at the same time, some other people come in, but they are under that contract. And if they come to the emergency room doc is going to internally say, I did 1 more unit of work because I just saw this patient. Internally, he or she will want some money, but externally, I'm not getting anything. I have the pool of money that I got. So where it gets really complicated is for us, the providers of care, because we make a point in our institution never to know by the physician who is the insurance provider of the patient that we're seeing. Many of them, as you know, at the University of Washington, have no insurance at all. Some of them are Medicaid patients. We take them all the time. Some are Medicare patients. We take them all the time. Now, they pay very little at the end of the day for services, but they still pay for services. Other patients are Boeing contracts or PEB contracts, you know, the healthcare authority contracts. We don't get a cent for that, right? We get the lump of money. So if in this population here, I did not know who has what, and half of you were on the fee-for-service side, and half of you were on the risk side, it becomes very difficult to manage for processes of management, you know? Ultimately, because we're going to devise methodologies that decrease the testing, decrease the number of operations, decrease the number of visits, and do all of that, which is great, but we're going to go down the drains if we do that to the fee-for-service paying people, because that is the only way that they compensate us, right? If we were on the risk side, we keep you all healthy, but we get a chunk of money regardless of you being kept safe. But if this half here is on the fee-for-service, and I apply the same measures that I will apply to this ones where I bear the risk, I don't get any money for any one of you whose services are not being provided. And therefore, it's very difficult to
So
to
this
run.
is really scary because you're running 2 business models at the same time.
Exactly. And 2 opposite business
Yeah,
models.
very different. And why are you doing this? The only reason I can think you're doing this is because you really think that the world is going to tilt,
Yes.
and you need to suffer through this season of
Change.
change. Is that fair?
Yeah, I think it's fair. And the predictions, if you look at the predictions of those who have said we know, the predictions way back when, 5 years ago or so, shortly after the passage of the Accountable Care Act, was this whole process is going to tilt in 3 years, 4 years. By 2016, 2017, we will be on the value world. 90% of services will be paid under that. So design a system that works on the value world, and you live with it.
But so if you just look through the value lens, what do you need from innovators? How are you going to relate to innovators? And how do you want them to think? They're going to have to show up with innovations that are persuasively make the value proposition. Quality gets better and cost goes down, and that they need to be thinking about that now. Is that good advice to them?
I think it's an excellent advice. I think it's an excellent advice, primarily because he gave it to you. But no, I'm not kidding. Look, not only I do that, I have for several years been involved in a relatively unknown type of organization that has that principle. And the principle is, if you really want to innovate, don't come up with a new product that costs a tremendous amount, that doesn't work with the existing infrastructure, but come up with processes and functions and things that improve quality, that improve care, that essentially prevent re-hospital admissions, keep patients out of the hospital, treat them in ambulatory clinics, and are not expensive. You have to think of value on the way that we were talking about before. You have to say, this is neat, this is great, but how much is this going to cost? For how much outcome am I going to get from that? And that outcome will have to be measured in terms of how does this facilitate the care of the patient? How does this facilitate the transition of patients from one place to another, if it's a software application or something of that nature? How is this going to impact the system where I'm at?
Healthcare is the biggest industry in the United States economy, but it appears to be the least impacted by IT. Every other industry has been transformed by IT. What's the prognosis? It strikes me as particularly complicated because healthcare is complicated, but it also is complicated by the fact what I call the sociology of software. We have educated ourselves to believe that software is quick and fast and profitable, and yet I think healthcare is a place to get eaten alive by the complexities. So what is your sense of the power or the potential of IT in health, in care transformation and the move towards value? Can those?
I absolutely, without a question, think that it can help, but it has to be a different thinking than the way that it is right now. Right now, it's a horrendous problem. When you talk about electronic health records, we spend next year about $200 million on the electronic health record only, on keeping electronic health record going. It is extraordinarily complex to manage. You spend, as a physician, half your time doing electronic health record as you spend seeing a patient or more. So there's a beauty to it too, okay? We could not do population management if we didn't have all the electronic health records. I can put all your records together and in the morning say, I have 5 patients that need a mammogram, 6 patients that need a colonoscopy, etc. So there is a side to it. But it's so complex, it's so difficult, it's so horrendous that it doesn't work. But I have seen applications now coming up that you say, wow, that is what you need.
From all the things you said, it looks like you're doing a lot of stuff on the provider side and the system side, but it seems like one of the biggest gaps still is patients. They don't follow what you tell them to do. Don't take medication, nobody exercises, not in general, but, well, that's more in general. It just seems like that's a big hole in the issue. And I was thinking about what you were saying about the Boeing contract. I know in talking with people from Providence and UW, it hasn't worked well out on their side. It's just kind of costing them a bunch because the patients that signed up happen to be the sickest ones, and it's costing them a lot of money. But it looks like the patients paid less for that. So once again, you've got patients paying less money, and there's no motivation for them to really take care of themselves. How can you get that part fixed?
And I think that that's a great question, and the answer is complex because we know that on the one side, we have the social determinants of health, and we know that the studies in general will support the idea that health care, which is where I am in, health care, can probably make a difference of about 10% on health in general. Because health in general is a product of education, it's a product of ability to move forward, it's a product related to race, related to religion, related to diversity, related to a number of things that come together to determine your status of health. And paradoxically, as it may seem on the surface, is not that when you got sick, you got the proper care. That is probably the easiest part. That's where the 10% estimate comes from. But in general, it's everything that precedes that. So we need educational programs. We need now that we work together with the companies like Boeing, and Boeing is very responsible in that sense, and is asking employees to do that. We need bonuses, we need incentivation programs, we need educational programs, we need time for people to exercise, we need them to engage in all the things that determine the state of health of a person, rather than focusing exclusively on, okay, when they get sick, you pay me this, I take that, I send it back to you, I hope the back pain is gone, kind of thing.
I wanted to ask about your comments about the EHR system. So you mentioned that you paid $200 million to maintain Epic. And I wanted to ask, do you feel the EHR as a way just to meet your needs of documenting on patients, on ordering electronically, doing billing, or do you see it also as a way to innovate as well because you have all this data that you now own and you could run your own research on it and then conduct new innovative technologies built around that data?
Great. I think it's a great question. So we do the latter. The short answer is we do the latter. We try to do the innovation. Let me tell you, you said, for example, EHR is important because you can order things. Think for a moment. You used to come to see me, right? And I'll give you a prescription. And I write in the prescription in a piece of paper, do this, this, and that, take this pill twice a day. Lots of errors in the writing, lots of errors in the prescription. Sometimes I would say 1 milligram, 1.5 milligrams. Pharmacist reads 1.5, they said 15. So all kinds of potential errors with a piece of paper that you then take to a pharmacy. Today, we put it in the EHR. You come, you see me, I want to give you that. If I put 15 without the point in between the 1 and the 5, the computer says, that's an excessive dose. Do you really want to give it? Push here. You can override the computer, but it's an active thing. Second thing, the computer says, oops, you said warfarin is 7.5. He's already taking vitamin D. Can't be the two together, so it brings you that up. You say, Jesus, what is the dosage of this particular medication, just to make sure? Information. I mean, in the same prescription thing, when you write just the name of the product, you push the little button, and it gives you every contraindication, every thought. Watch out. It may be a pregnant woman that you're giving it to, all kinds of things. So the power is huge. But then think of the population that we said. Impossible to manage the population. Now you come and you leave that trace, right? And of course I send it electronically to a pharmacist who has it in the pharmacy electronically, but the pharmacy is connected electronically with every other pharmacy, and they said, hey, he's getting opioids from that pharmacy. You're asking me to get it from here. I see that he's getting into 3 other pharmacies, plus there's a red line here. All those kinds of things can happen. So the electronic health record opens a huge potential for us to deliver better care. And I don't mean to put it down. We do have now, every physician that is doing primary care, we have about 300 of those, has a panel of somewhere between 1,000 and 2,200 patients for whom she or he is responsible for. And in those 2,200 patients, you come in the morning and say, today is Monday, let me see if any one of my patients came to the emergency room. And it shows you the 2 that went to an emergency room. You click on them and say, I want to see why they went to the emergency room. Oops, they had this, they had that. They are in the hospital right now, I got to see them. The kinds of things that you would never have an opportunity not to do before. So they are useful. I'm just saying that because of all the regulations and because of the competitiveness of the market, and because frankly there was a lot of money in healthcare to be made, companies just abuse the system. And so we have a Cerner system that does not talk to the Epic system, and so those are 2 large systems around the country. We have an Epic system in our hospital that doesn't talk to any other Epic system in any other hospital, and any other Epic system in the other hospitals don't talk to the other Epic system because they're different instances of Epic. So they don't talk the same language. So we can't communicate. So what we need is to have appropriate interactions, and that's where I think the future lies.